and it was really nice to get the Rebecca's version to start with, and then I'm sure there'll be many questions later. It's my absolute pleasure to introduce Laura Chapman. She's a transplant coordinator at Sydney Children's Hospital. We've had many emails and many chats, but I finally got to meet you today, so I look forward to your talk on CAR T cells. Thanks.
Thank you, everybody. Which button do you use? This it's that one in the middle, isn't it?
Yeah.
I'm going to talk to.
I don't know if you can see over there.
Oh yes,
you have to stand over to the left.
Yeah.
And we don't have a milk crate for anybody to stand.
It's a good job. I'll probably fall off with nerves. Today I'm going to talk to you about chimeric antigen receptor T cells, and for everybody in this room, you're all immunology, and you're probably thinking, what on earth is somebody from oncology doing here? But actually it does have something to do with immunology, because it is a form of immunotherapy, actually classified as a living drug. Very exciting world that we live in. And it's, genetically manipulated T cells that target specific tumour antigens, essentially. And there are a number of approved CAR T cells within Australia, and these are actually the adult setting ones that we have in Australia. And for the purpose of this talk, we're actually going to talk about B-cell acute lymphoblastic leukemia in paediatrics. And the Australian government has very strict guidelines of the funding of CAR T cells as extremely expensive therapy, extremely expensive. So there's very strict guidelines for the children to be able to be eligible for the product. So what are they? First of all, we'll just look at B-cell ALL. It's the most common form of childhood leukemia, with overall success rates exceeding 85% actually. So your run-of-the-mill B-cell ALL that comes in, very easily treated, absolutely grand. However, if you're a poor player and you have relapsed or refractory disease whereby conventional chemotherapy is not working, you've got a very tricky disease, it's very crafty, your chance of cure remains really, really low. So the patient's genetically own modified T cells are actually made in this scenario that we're talking about now with B-cell ALL to recognise the antigen of CD19 positive on the surface of B cells as foreign and mount and attach that specific antigen. Here's the T cell here that's being manufactured. It's got a little peptide binding groove, and I like to think of it as a jigsaw puzzle. It will only fit on to that other B cell there, which is the specific antigen. Any other pathogen or antigen that is out there, it will just bypass. How are they made? The child goes on to an apheresis machine for the day, where we hive off T cells and they're frozen down in our BMT lab. They are then sent over to America for reprogramming. The whole process takes about 28 days to 1 month, where the CAR T cells are made and multiplied into the millions. They get sent back to us. The child's in a tricky position at this point because they might have actual disease burden in them. So they might need a little bit of chemotherapy just to calm things down, a little bit anxiety provoking for the parents. Then the child has some fludarabine and cyclophosphamide lymphodepletion, which makes the CAR T cells grow into the millions inside them. And the CARs are actually infused themselves, which is highly underwhelming. It's like 5, 10 to 30 mils of product. The mode of action, over in the labs over the scientists in America pop in a dormant or lentiviral vector such as CMV or HIV to actually get the genetic information into the inside of the cell, where the cell is reprogrammed into a CAR, and then causing apoptosis and cell death of that particular antigen. The product that we use over here is called tisagenlecleucel, and that's the last time I'm going to say this in this talk. I will refer to it from now on as the product called Kymriah, made by Novartis, because that's just too much to comprehend. This was absolutely groundbreaking. This is a paper backed by Stephen Grupp from CHOP, and it shows basically that we had an event-free survival of 50% over a year's period. So bearing in mind these are very poor players and wouldn't have been able to have treatment for anything else and would have ended up palliative, it was absolutely groundbreaking. This is just an overview of some of our patients. I'm missing a few off here, I'm afraid, because we've had a few more since. But basically saying that all poor players, some are post-transplant that have relapsed, some are refractory to chemotherapy, and some have got CNS disease burden, and we'll come back to these children afterwards. Side effects, obviously every therapy that we give has certain side effects, and the side effects of CAR T cells can be really quite nasty. You know more about cytokines in this room than what I do, but basically they're chemical messengers that regulate immunity and inflammation. They're what makes you feel like absolute crap really when you have the flu. They're rallying up the troops, saying you need to do this, you need to do that, causing massive expansion of T cells and B cells. And it becomes an issue with cytokine release syndrome for CAR T cell therapy because pro-inflammatory cytokines, particularly interleukin-6, worsen inflammation, and we get excessive production of cytokines which just do not calm down with anything. It usually occurs within 3 to 9 days post the infusion of CAR T cells. And of course, it goes without saying that if you've got a bulky disease going into the actual therapy, you would think you're at a higher risk of CRS just because of the amount of activity that's going to take place. Approximately 1 to 4 children will develop CRS, and the fundamental main manifestation actually is fever, so that's a grade 1 CRS. Obviously, you'll get associated sinus tachycardia. Hypotension is the one thing that will get the child and adult, this is the same in adults by the way, same side effects, into the ICU actually, noting a widening pulse pressure before they have a wobble and drop. And hypoxia can also occur. Management of CRS is aggressive supportive care. Bearing in mind that these children do go into a neutropenic phase, so we need to make sure that we follow our febrile neutropenic pathway, because it'd be awful if we thought this was CRS and it's actually sepsis that's causing it. So we need to make sure that we give them antibiotics. And blood pressure parameters for children need to be recorded in accordance to age. We need to make sure that we know when they're going to have a wobble, right, we need to inform the doctor at this particular point. All children that have CAR T cell therapy, the ICU is made aware that they're going to have the therapy just in case they need to be immediately put down to ICU. Basically, the treatment is at grade 2, earlier the better, and we give aggressive treatment for hypotension, so 2 crystalloid boluses, and therefore they then need to go down to the ICU for IAL support, including vasopressor support as well. That's important. As soon as you've given your first bolus, you need to let the ICU know that we've given the first bolus and get the bed ready, basically. Oxygen administration can happen from low flow to full-on intubation. But the mainstay treatment for CRS is the administration of tocilizumab. And what actually happened was the first child, Emily Whitehead, over in the USA over 10 years ago now, was sick as a dog with CRS. And she's the first child to have CAR T cells, and all the doctors were stood around the bedside thinking, what on earth are we going to do? Because she was intubated, ventilated on multiple inotropes at that point. And luckily, or unluckily for the doctor, he said, my daughter has rheumatoid arthritis, and her interleukin-6 was sky high because they'd measured it, and she's on a drug called tocilizumab to reduce and calm down the cytokines. So let's give some tocilizumab. So that's actually what they did, and it actually saved her life. And the reason now why paediatrics is able to have CAR T cell therapy actually, so it's a very lucky kind of scenario when you think about it. We always have tocilizumab available in the emergency drug cupboard, just to make sure that it doesn't get lost in the actual ward, and that we know where to get it and an SOP to follow for administration. Now, steroids should be avoided where possible. We do have an EMR flashing up if a JMO comes in the middle of the night and just thinks, oh, let's just give some prednisone to calm this down. It will actually come up with a thing to say you can't prescribe, you need to speak to the transplant team, because it's thought to dampen activity of the CAR, although recent literature does go against that. Of course, there's a grading system there by ASBMT, and you can see there that grade 1 is just a temperature alone, going to grade 4, which there probably are multiple inotropes, plus or minus being intubated. Now, although frightening, CRS is very medically managed, and once they're in the ICU, it's up to them to take over the responsibility. But Looking at another side effect called immune effector cell-associated neurotoxicity syndrome. There's always massive words in these things. It's a whole different ball game, really. Neurology I always find quite frightening. Approximately 40% of children will develop ICANS. And it's thought to be just like a pro-inflammatory cytokines crossing over. You can actually see CAR T cells cross over very well into the CSF space. And so if you've got CNS disease, you would increase your chance, you would think, of ICANS itself. It usually occurs 1 week post-CAR T cell therapy, but can occur up to 60 days, and that's very, very important. There have been late players that have been discharged into the community and have come back either into the emergency department or to the oncology department. And the parents have said they're just not quite right. I can't put my word, I just can't put my finger on it. They're just not quite normal in themselves. And it actually can be a late playing ICANS. And this has happened. There has had a child treated within Australasia who succumbed to ICANS actually, and they were a very late player getting it. And another child remains disabled as a consequence of ICANS. So it is quite it's serious thing. Can also overlap with CRS. The manifestations are wide. Delirium, encephalopathy, seizures can occur, and status can occur as well. Of course, there's a grading system. It's graded from 1 to 4, and there's 2 different types of grading system that we use. Children above the age of 12 have the ICE assessment done, with the higher score being the better, so they're orientated to year, month, city, hospital, etc. And the CAPD grading system is used for children under the age of 12, and the EMR will automatically, again, according to age, ping up the right one when the nursing staff are doing it. Quite complicated. It's the lower the score, the better, so they're often done incorrectly because people get mixed up. But does the child make eye contact with the caregiver? Always is a 0. Overall grading, it gets a little bit muddled here because there's a lot going on and there's a lot being mixed up. So essentially we leave it to the doctors to make that decision, but goes without saying that grade 4 you're in the ICU at that point. ICANS treatment is mainly supportive care actually. It's very important that nursing staff assist with the rapid recognition of ICANS and listen to what the parents or caregivers are saying. If they are saying something subtle, it needs to be looked at and thought of, maybe the neurology team need to come and actually look at the child. Supportive care is the main stay of safety for the child, just making sure that the cot sides, etc. are up and they're in a safe environment. Airway protection being particularly important in the for loss of consciousness. And we do reserve corticosteroids for neurotoxicity, with dexamethasone being the choice that we give, although we've never had to give it in our centre, just because it crosses the blood-brain barrier quite well. Short course and a rapid wean. Just going back to our children now, so we've said that if you've got bulky disease coming in or CNS positive, you're at risk of both CRS and ICANS. And what we can see here is actually with our players that that's not necessarily true. Oh gosh, how to go backwards? Oh, like that. What you can see here is this patient here, he's had a second CAR now actually because he did relapse a year and a half post his first CAR. But he had bulky disease going in and just had 1 temperature and had, grade 1 CRS. You can see this child here came in with low disease bulk, but was intubated and ventilated in the ICU with very, sick as a dog actually with CRS. You can also see that in the beginning we were giving tocilizumab left, right and centre because we were a bit like, whoo, let's just give it. And then we've got a patient here who had a bit of disease but was CNS negative, but was intubated and ventilated for grade 4 ICANS, but actually got discharged 3 days later, actually discharged from the ICU, walking out nice and happy and lowery, but quite frightening. There are other associated side effects, tumor lysis syndrome and HLH. Cytopenias can occur up to about 6 weeks post-therapy with low neutrophils and platelets. We do have to be careful for viral reactivation. Now obviously we've got CAR T cells going around and they are going to get rid of all the B cells that are there. Hopefully they can continue to do that. That means that they have B cell aplasia, which means that they are at low risk of relapse because that's what you're wanting. So we have to make sure that they have IVIG therapy for the time. and they're followed up very closely for about 15 years because it's a new therapy. Just looking at some outcomes, this is fairly reproducible to the paper that I showed you earlier on in the slides there. This is from 2020. It's saying that, you know, there's about 40 to 50% chance of overall survival. So okay-ish. Moving forward, this is very new literature out from 2023. They've looked back at the children that have gone through therapy, and minimal residual disease, so that's disease burden going in, pre-infusion at day 28 and 3 months is a very important risk factor. So if they go in with negative disease, their chance of relapsing is a lot less than what they do if they go with positive disease. And timing of return of B cells is extremely important. It's indicative of outcome. Obviously, B cell aplasia is better for an outcome, but if they're starting to get B cells coming back in 3 to 6 months after they've had their CARs, it's a very poor prognostic factor. Just moving forward, the dose infused that we give makes a big difference. The larger dose that we actually infuse to the patient has a better outcome. Now, unfortunately, Kymriah or Novartis are in charge of the cell doses. They generally make 3 doses actually and keep 2 and then send us 1. We're not in charge of the cell dose. They give us what they give. But moving forward, CAR T-cell therapy is going at a rapid pace into other cancers. We've just opened our first trial for brain tumours. Thought of that with ICANS, makes me feel quite unwell. But yes, we're heading for our first brain tumour CAR in September if her scans are okay. And then we're moving forward into AML and T-cell ALL. So in summary, CAR T-cells are a form of immunotherapy. Patients are at risk of CRS, ICANS and HLH. Tocilizumab treats CRS. They're good for getting children into remission, but CAR T-cells don't always last. And there is a drug out there called pembrolizumab, but we have used a couple of times to actually have persistence of the CARs. But unfortunately, CAR T-cells may not be the answer for everyone. We can see that they're starting to drop off on those curves over time. And we should avoid corticosteroids where possible. And then this is the girl that I was talking about, Emily Whitehead. She was the first paediatric patient, and she's over 10 years now free of cancer. Thank you.
Thanks, Laura, that's great. So now I get the opportunity to introduce Anna Sullivan from, she's a clinical nurse consultant working towards a nurse practitioner in immunology and allergy at the Queensland Children's Hospital, and she's going to be talking about hyper IgM syndrome.